Thank you so much for being here. I'm Emily Cummins. I'm a postdoctoral researcher at Boston Medical Center, and I'm the moderator. And so I will start by introducing our panelists. So we have with us today Sergeant David Costa from the Beverly, Massachusetts Police Department. Thank you so much for being here, Sergeant. And we also have with us Chris Alba, who is a harm reductionist and outreach worker with Healthy Streets program in Lynn, Mass, who also works closely with the Beverly Police Department, among other programs. And then we have with us Brittany Riley, who works for the Massachusetts Department of Public Health. And then we have with us Dr. Jennifer Carroll, who is a professor of anthropology at Elon University in North Carolina. And so what we're going to do first is have Dr. Carroll orient us to the study that we're going to present here, which was a CDC-funded grant looking at post-overdose outreach programs across the state of Massachusetts. And so we've done both some quantitative and qualitative work looking at what that looks like across the state. Several of our panelists here have been very helpful and have even participated in that research. So Dr. Carroll will first present that research, and then what we'll do is open it up for some questions that our panelists are really in a good place to address. So we really look forward to hearing from everyone. So I will turn it over now to Dr. Carroll.
Awesome. Thank you so much for that introduction, Emily. And thanks to everyone who's been organizing this conference. I was thinking earlier, I can't really say that I have enjoyed this online conference more than other online conferences because I haven't really enjoyed any other online conferences this year. But the content and the people that have come together has just been really exciting and invigorating. And I know that moving stuff online is I don't know, basically like a carnival of errors all the time. So I appreciate everyone's like hard work and humility and just repeated tenacity in showing up so that we can all be here together. So what I'm going to be doing is running briefly through some of the research that's happened. I do have the chat open. So Hannah, if I happen to go over, please feel free to throw out a hook to pull me back in there. I do want to say that the vast majority of this research or the data that I'm about to present was collected by other members of our study team in the form of a survey. And then we're also going to be sharing some qualitative data that Emily herself, Dr. Cummins, has been able to collect over the last year. She is a superlative ethnographer who's been great to have on this team. So I'm really kind of, I have the luxury of sharing her work, but we want to save her energies to moderate this really great panel. So this was basically our study design. We conducted a cross-sectional survey of post-overdose outreach programs across the state of Massachusetts, as well as in-depth qualitative interviews with program staff, and more recently with people who have been targets of that outreach, survivors of non-fatal overdose and their family members, who will be focusing on the first bit. And for those who might not be fully familiar with the idea, a post-overdose outreach program is where there is follow-up with an individual following a non-fatal, typically following a non-fatal overdose within a day, 72 hours, a week. It depends, to connect them with services, see how they're doing, see if this is possibly a place where there is an impetus for help seeking or linkage with care. These programs have really mushroomed a lot. So this is a map of the state of Massachusetts that shows what municipalities had these programs in 2015 versus at the survey that we did in 2019. It has grown dramatically. It's become a very, very popular sort of program. And so that's why we set out to evaluate them, because they hadn't previously been evaluated. We didn't really understand what sort of impact they were having on the community. So our survey findings show a few trends within the state of Massachusetts specifically. If you look on the upper left, that table tells us that the vast majority of outreach teams include a sworn officer. We also very frequently have recovery coach, harm reduction providers, social service professionals, but a real mix of other professional roles outside of law enforcement accompanying a law enforcement officer. The services that are provided are also pretty common across the board. More than 90% of programs provide treatment navigation for substance use disorder, referral to abstinence-based inpatient, referral to outpatient medications for opioid use disorder, recovery support services, overdose prevention like naloxone, things like that. And we have a lot of also common trends in terms of team size, how they do it, how long things last. It's typically, more often than not, a team of 2 going to the known address of the overdose survivor, an initial visit that lasts pretty quick, usually 1 to 20 minutes. That the team philosophy by self-report is more harm reduction oriented, and most people will always engage with what we're calling the social network. So the roommate, the mom, the uncle, the friend, spouse of whoever has been affected by an overdose crisis, even if that person is not at home. So our qualitative findings have I think raised a lot of really interesting questions. We did conduct interviews with, I say we, Emily has done a ton of hard work on this. She has conducted interviews so far with 38 people who are involved in doing this work in regions all across Massachusetts. So we tried to get a really wide representation. About half of those were with sworn officers, the other half with folks of other social roles. And so here's a brief overview of some of the questions that have arisen, right? So qualitative data can't tell us how frequently something is happening. It can't tell us how often something is succeeding or failing. All qualitative data tells us is that these are things that happen in the world, right? So these are things that happen more or less in the world of post-overdose outreach in Massachusetts. We've learned that in some places, and this has come up in other panels, that going out with marked cars or police in uniform, even police in soft uniform, causes problems, while it makes a huge difference in terms of professional appearance to be in a full uniform versus like a polo. Like folks opening the door aren't really like taking a lot of different information from those 2 types of dress, and that law enforcement often takes the lead on these teams. So they're the ones to approach the house, to knock on the door, to assess the scene, and also it's really hard for folks to agree about what makes a successful visit. And this isn't simply a law enforcement versus public health or community health divide. It's actually much more granular and much more nuanced than that, and it could really vary from person to person regardless of their professional orientation. We know that mandated treatment, you can also call it involuntary commitment, you can also call it civil commitment, there's a lot of names for it, but this is essentially where someone will petition a judge and have someone essentially taken into custody and brought into mandated care. It's different than a 72-hour hold that we often associate with a psychiatric crisis. This is something that does exist in Massachusetts, and it seems in general that law enforcement officers are slightly more comfortable talking about mandated home visits, but that more often than not, it is family members who are bringing this up. So a team will go to the house and it will be the spouse, the daughter, the dad, whoever at the kitchen table who is asking about this and whether or not the team can help them do it. I think that was sort of not something that we fully anticipated when we started this project. So that's a really interesting sort of finding. We also are finding that the way to deal with warrants and arrests is kind of a head scratcher, is Emily's term. I like that a lot. Everyone seems to deal with it a little bit differently. And while everyone has their opinions about what is the best way to do, we don't really have a lot of information that tells us that one way is clearly better than another way. We only have the guidance that our own philosophies and values bring to that particular decision. But it does raise the point that there can be conflicts. If you have a law enforcement officer who is attending an outreach visit as part of this community-oriented team, but they learn that there is an open warrant perhaps for someone who they're going to visit, how they choose to resolve that conflict ultimately is an open question. We see it happening in a bunch of different ways, and it's not fully clear how one way or another creates or resolves more problems for the people receiving the outreach, creates or resolves more problems for the officer involved in outreach. It's a big can of worms that we're still sifting through, and I think is still very much a source of discussion. And then this is something that, at least on our team, with me and Emily and our other study team members, we've been talking about a lot lately, this question about scene safety. There was actually another panel here even that I was listening to a few days ago where the suggestion was made that having law enforcement officers as part of the outreach team was appropriate, and that one of those reasons was that there is an ongoing concern for the safety of the other people on the team, and in addition to other reasons reasons that might apply as to why it's appropriate to have them there. Sorry, my cat is trying to co-present with me. So one question that we have been talking about is whether or not this concern is really, I think, adequately assessed, right? I was part of another study a while ago that found that 95% of officers that we surveyed in a group of almost 3,000 officers agreed very strongly that it was important to have law enforcement on the scene post-overdose, like immediately after someone has been given emergency services and reversed, in order to protect the safety of medical personnel. At the same time, you know, before I was a researcher, I was a Head Start teacher. I did home visits all the time. And so I bring a kind of different perspective to what that might mean. So I think this is something that I'm really looking forward to talking about in our conversation. What actually are the safety concerns, and to what degree does the presence of law enforcement increase, reduce, or have no effect on the safety of people who are doing outreach? So these are questions for our discussion. I will kind of let these sink in real quick, and then I will stop sharing my screen so we can let other people sort of take the floor. But these are open things that I think that we all think are really important for conversation. So what possibilities or problems arise when harm reductionists seek partnerships with law enforcement? Are there shared success stories? Is there conflict that has arisen out of this? Is that conflict limited to the people involved, or does it have larger effect on the community? How do post-overdose outreach programs change viewpoints of public health and public safety in ways that are both intended and desirable, or not intended and possibly having various impacts? How should programs handle things like someone refusing transport, someone refusing protective custody, dealing with things like Section 35 or that mandated treatment? And then what about overdose survivors who don't call 911? The vast majority of the people who are targeted by this outreach are identified through police records or emergency call logs, something similar. So there is a question of sample bias, right? Who are these programs missing? And can those people be engaged? Should they be engaged? So on and so forth. So I will stop there, and I will turn it back over to Emily to get our conversation started.
Great. So thank you all so much. And thank you, Dr. Carroll, for that wonderful presentation. So now I'd just like to open up the floor to those questions. And I would love to first hear from our panelists, the immediate thoughts you have, thoughts about the work that you're doing, and how you sort of want to direct the conversation for the rest of our time. And maybe we can start sort of with, you know, this first question, like so Sergeant Costa and Chris, like what has your experience been in this partnership, law enforcement and someone who's sort of coming from, you know, more harm reductionist kind of perspective? Like how has this partnership developed? Like what have the challenges been? Maybe that would be a good place to start if you could sort of like describe your experience. Not to put you all on the spot, but we just really want to hear from you.
Yeah, no, I mean, for the police, it's been a good program as far as building relationships with the community and you know, people who are you know using substances and dealing with addiction and things like that. Yeah, it's been a good learning. It's been a good learning experience working with Chris, because addiction is something that I haven't dealt with personally, and so to learn from his experiences and you know, the things that he feels or he's felt in the past and things like that, it's kind of been eye-opening for me. So you know, it's certainly an educational thing for me, but I've also been surprised at how open people have been to our visits. I mean, I kind of thought that nobody would answer the door when we knocked on the door, and what I find is that many people, the majority of people, answer the door, not only answer the door, but invite us in. COVID, but you know, invite us in and talk to us. So it's been pretty good as far as learning from everybody and kind of hopefully building our relationship and you know, people's view of the police and how we respond to things.
Sergeant Costa, do you feel that the community is responding differently to police since this program has started? Like, have you felt kind of a change in the way that maybe community members respond to officers? Do you think there's been any effect with that in terms of the program?
Yeah, I think people are more open. I
Mhm.
feel like even when officers are responding to, the initial overdose call, I think there's more
Mhm.
of just a better feeling of being there rather than thinking, oh crap, they're here to arrest me. It's more of a,
Mhm.
yeah, I feel like that might be the case, and they're kind of more welcoming, I guess.
Mhm.
Yeah,
Mhm.
but
Yeah.
I definitely think if people are more open to it.
Mhm. Chris, what has your experience been like working in this space and working with law enforcement officers?
It's it has its ups and it has its downs. There's a lot of education that goes on both sides. I'm learning a lot from them.
Mhm.
I'm seeing their side of what's going on, and I try and do my best to educate some of the people I go out with.
Mhm.
I just want to clarify, we do not take part in Section 35s when we go out. We do not take part in civil commitments.
Mhm.
I don't know what your data shows, but once we do that, you
Mhm.
lose all trust with anybody, and
Yep.
it also has a high fatality rate upon
Yep.
leaving. So I just want to
Mhm.
clarify that we do not, absolutely do not take part in the civil commitment process.
Mhm.
That's a good way to lose trust in people.
Mhm.
But
Yeah.
as far as the relationship, I was very skeptical going into this, whether or not they would open the door, whether or not I was the right person to be in the car with these people. And through the conversations we have, I've seen a lot of people from law enforcement calling me and saying, like, listen, I know I can arrest this person, but I don't want to. Can you kind of just talk to them, or can I send them down to see you? And someone's not getting arrested for a minor crime that they shouldn't have to go, sit in jail and bail themselves out. And so they're seeing, we're helping understand the human side of what's going on, and reducing some of the harms and dangers that are caused by law enforcement.
Mhm. Brittany, I'd love to hear, oh, sorry. Brittany, I'd love to hear your thoughts too on this, on sort of your work with the post programs and how you see this taking shape.
Sure. So from, the Department of Public Health perspective, we try to follow the data, we try to follow the field. And so, in my role, like what's important to me is listening to the providers, listening to folks like Chris, and hearing, what's going on, what's promising, and then, doing what we can to back them up. So, what can I do? I can show data. I can, point different groups into the direction of, hey, have you looked at, our big data linkage project we did at the state that shows that, periods of abstinence are a critical risk factor for fatal overdoses. And so making sure that folks have that information, understand if you're going to, help, support someone and they want to go to, an inpatient, detox program, that comes with risk. And so you have to talk to the person and offer them the full menu of options. So we try to, be, conveyors of information, make sure that folks have access to resources to understand risk factors for fatal overdose. Do our best to explain to partners, why a harm reduction approach makes sense for this setting, why, putting someone in, going the arrest pathway can really interrupt someone's life, especially if they have, a variety of health and wellness goals that they're working on. So, we try to really support the providers and provide education and information to their public safety partners, and also make sure the public safety partners have access to important resources such as, funding support for naloxone and training on overdose prevention, and, making sure that they have information around, jail diversion practices and why, not arresting someone can help, them achieve their health and wellness goals down the line. So that's sort of, our role is, funding evaluation, funding the field and trying to listen to the field and go where they're going while understanding who are our partners. I think in Massachusetts, we have syringe access programs, and, for municipalities, there needs to be a, approval at the town level for a state-funded syringe service program to operate. And, law enforcement and public safety can be advocates for expanding access to syringe services. So thinking about, how can we be advocates for people who use drugs and, helping folks, not have their lives interrupted by incarceration and arrest, what's the information needed and how can we support just, the resources and education needed to expand access to syringes, expand access to all the supportive services that go along with syringe service programs. So sort of, my role is trying to, keep the trains running on time, make sure that people are getting paid, but also ensuring that resources are going in promising directions and that we're really listening to the field as much as we can.
Great. And Dr. Carroll, I want to give you space if I know you had something to say before, so.
What did I have to say? I'm sorry.
Oh, I thought you had something to say, but if not, no worries.
No, I probably just failed to mute my mic in a timely fashion. Also,
No worries.
Someone asked in the Q&A what Section 35 is. It's involuntary commitment, and I placed a more detailed answer in the Q&A there in text.
So, Chris, you mentioned that one of the challenges for you was sort of starting this partnership with law enforcement. Would you mind elaborating a little bit on that and like what it was that sort of maybe changed your mind about working with law enforcement? And then after that, maybe Sergeant Costa, you can sort of elaborate on what changed your mind about working with the other side.
So, I mean, I've been doing harm reduction for a long time. I've been giving out naloxone for a long time. And law enforcement at the beginning of this whole naloxone journey would, confiscate our naloxone and threaten to charge us with a Class C substance and say we were the reason if we didn't give out these things, we would, there wouldn't be a problem with addiction or drug use in the community. And, it's kind of like a bizarro universe where you fast forward a few years and I'm driving around in the cop cars with some of these law enforcement officers who now have a different take on it. And which just shows there's been a lot of good advocacy on the part of naloxone and stuff like that. So it's I've been in it since it was frowned upon, and now everybody's trying to jump on and kind of like this is the trendy thing to do, I guess. And so it's weird. What was the second part of your question? I'm sorry, I forgot.
Oh no, and then maybe Sergeant Costa, you can sort of elaborate on what it was like to kind of work with harm reduction partners as, from the law enforcement perspective.
Yeah, sure. Yeah, I think honestly, when we started hearing about the idea that you can connect people to services and get people help rather than arresting them, that we over the years have dealt with the same people over and over, the same situations over and over, and you get to a point where you see the same guy and you're like, okay, I see him on the street, I know what he's doing, I know what he's going to do, and it's just this like vicious cycle. And to find out that you can just kind of connect someone to a service and get them help, get them treatment, things like that, and find out that, oh, now I never have to worry about that again. I don't have to worry about somebody breaking into a car to fund their addiction or whatever. It just kind of seems like a no-brainer. And this wasn't certainly something that we started, or we just kind of saw other departments doing it and said, that looks like a pretty good program. And we jumped on board. I think more departments are seeing that. They're seeing the benefit of connecting people to services rather than arresting them over and over and over and over. It doesn't really solve anything. So, there's certainly some things we have to take seriously, but some smaller trivial stuff doesn't need to go that way. And, if I can kind of break that cycle and connect people to services, it just makes sense. And, most officers in our department are seeing the benefit of that to the point where, even, this started out as just responding as a post-overdose situation where we have an overdose, so we go visit them. Now it's to the point where I have officers calling me and emailing me and texting me and saying, hey, I dealt with, so-and-so on the street, and, he doesn't look like he's in a good way, and he could probably use a visit. And, that's that we're able to step in and do something before anything happens. So it's, in that sense, it's been really good. And I think, even just carrying Narcan, I mean, our department was on board with carrying it. I think probably in the beginning we didn't, sometimes you don't know what you don't know. And we didn't know what Narcan was. We didn't know, how to handle it. But I think, as soon as we started carrying it and using it, guys saw the benefit of it. And it, again, it just kind of clicks and you say, oh, geez, that's a good thing to use. So, that's what's kind of made, I think what's caused us to come around. And I think the goodwill was there before. We just didn't know what tools we had to use it, and to connect people and stuff like that.
Thank you so much. So we have a question from a participant that I want to pose to everyone, which is asking about the way that, potentially there are outdated drug policies, harms caused by law enforcement driven by these outdated drug policies. Are there conversations around this? And so, the audience member, asks people that, they come into contact with, don't want to call the police after an overdose because they're afraid of further criminalization. So I'd like to pose that to everyone.
I always make sure that these conversations, we have these like sometimes uncomfortable conversations in the car when we're out with the first responders. One of the biggest roadblocks to these programs was the definition of a success story. And sometimes the conversations in the car, like someone from law enforcement says, I never thought of it like that, are the biggest success stories. We're not pushing, the success story is defined by the person, any positive change and whatever he or she deems to be the change that they need. And that was one of the roadblocks. And these are conversations we have. We talk about possible decriminalization. We talk about the harms done by maybe arresting someone doing it. And we've been doing this for a long time. We've had a lot of conversations, and I mean, these are the things that I really like to have. This is my favorite part of doing this program, is having these conversations in the car with these guys.
Yeah, I think, obviously law enforcement are trained to enforce the law. And so if you're in possession of drugs and you have drugs on you, that's against the law. So it's not so much that we're out to get people. It's just, we're doing, for a while we were doing what we thought was our job. Now we're seeing that there's other options. And, I think that's kind of where the perspective is changing a little bit. You saw like the war on drugs and things like that. And I don't think that, we still need to address, arrest dealers and things like that, but we don't need to catch up the users in the crossfire, right, if you will, of, if we can connect them, kind of come at it from both angles. Maybe we're arresting, the dealers and helping the users. We're kind of coming at it from both angles and trying to kind of solve the problem in multiple ways. But, Chris mentioned the success stories. I still remember, one of our first, what I thought was a success story was, we got a person connected to a Suboxone program, got them into treatment. And I looked at, wasn't Chris at the time, I was working with another guy, Denny. And I looked at Denny, I said, wow, that's awesome. This is our first success story. And he looked at me and said, no, it's not. He said, he brought up a guy we had talked to a few weeks prior who was we had just stopped into the shelter. He was a gang member or trying to get out of gangs. And we started a conversation with him, and he didn't like me from the get-go just because of my affiliation with the police. But we had a conversation, and that conversation turned into this open line of communication where every time I went to the shelter, he would come running up and say hi and shake my hand. And he actually wanted to talk to me and tell me what was going on. things like that. That was a success story. And I never really thought of it that way. You know, building these relationships is the success story, not just connecting people to treatment. So, you know, we evolve. Everything we do, we evolve over time. And I think, you know, law enforcement is evolving, and, you know, we want to make the change, and we just need the tools and the education to know how to change and what we can do and how we can better approach this situation.
Yeah, so I wonder if I could put Dr. Carroll on the spot here, because she's done some research about sort of the relationship between dealers and users. And I wonder if you would mind elaborating on that, Dr. Carroll.
Yeah, you read my mind. Thank you. Yeah, so I want to, I think, respectfully push back on this notion that there is a distinction between people who use and people who deal. I think we have an astonishing amount of very rigorous scientific evidence that tells us that these are by and large the same people. And we know from some of John Zibel's research in Ohio that drug seizures are directly related in a time sequence way with overdose. So like after a drug seizure happens, more people overdose. We know from my research in Rhode Island that people are at significantly greater risk of overdose after their primary dealer is arrested, and that person is usually a friend, cousin, roommate, whatever. And also we know from the research done by the Health and Justice Action Lab led by Leo Beletsky that the people who tend to receive the harshest sentences for dealing, so what was it called? Enhanced prosecution up to manslaughter and homicide, tend to be the friends, brothers, spouses, roommates of the people who have unfortunately lost their lives to overdose. And I think one thing that I wanted to mention, the last time I was in Philadelphia, which thanks to the pandemic has been way too long, I think it was like 2017 or 2018, I had a really good conversation with Jerry Daly, the director of the Mid-Atlantic HIDA that's based there, about this conversation of, it puts officers in a bind. And I agree, it puts officers in an extremely unfair bind to say, possession of substances or public intoxication with substance use is illegal, and then also be like, now be nice to people and go out into the community and give them naloxone and love them. And I think that's a great set of instructions, right? I ask everyone to go into the community and love each other and pass out naloxone, and that's great. I recognize that is in a lot of ways fundamentally unfair, and that sets a lot of folks who are sworn officers up for failure. I mean, as I mentioned briefly in the overview of the findings, like, warrants pose a problem, right? And it doesn't present an easy solution because we have essentially provided officers with conflicting charges. And so how they choose to navigate that conflict really depends on like their gut, right? And we know that gut is like the best way to lead us down the wrong pathway. So, one of the things that Jerry Daly said to me that has stayed with me for a long time was that, this conflict is fundamentally unfair for officers. And I agree with that. And this conversation happened in the context of a harm reduction meeting and a harm reduction visit, and also like a harm reduction learning opportunity. And so I think a question that I have, not necessarily for the panelists, but just for all of us, is if that's the case, then why aren't we seeing more law enforcement pushing for decriminalization, right? I think in my experience, if you have law enforcement going to local government or state government and pushing for a particular law, there is no reason to fight. Like, you're just going to waste your energy fighting against law enforcement, right? There is no more powerful constituency that state government and local government listens to. And so if we had a law enforcement stepping up and being like, hey, this sets us up for failure, change it, it would be changed by now. I truly believe that. And so I think, so yeah, I don't want to, feel free to push back, answer, disagree, whatever you like. I don't mean to put anyone specifically on the spot, but I think that's a question I've been sitting with for a while. I would really love to see that as well.
The one response I'd have to that is like using marijuana as an example. Marijuana is now legal in Massachusetts, and as much as the voters voted for it to be legal and were for it, we still have tons and tons of people who call and say, people are smoking marijuana. You got to do something about it. It's like, so, we have people on one side saying, we need to decriminalize this and we need to help people and we need to do that. And we have people on the other side telling us, other citizens telling us that you need to arrest these people. You need to do something. This is a problem. And so it's kind of hard to, like you said, you kind of have to trust your gut and kind of do what you think is right. But it's like, you know, who do I appease? Who do I listen to? Who's you know, what is right is kind of between, it's just subjective, you know, to everybody, and everybody has their own perspective. And unfortunately, and it goes with every law. I mean, if cars are out speeding and we're out stopping cars, there's people saying, that's great, you guys are keeping us safe. But there's another half of people who are saying, you're harassing people, you shouldn't be stopping people. So we're kind of stuck in the middle of all of it. And that's kind of part of what we deal with.
Yeah, you make a really, really good point that calls for service are an enormous systemic pressure on what police are obligated to do. And that, I mean, we see the same, my colleague Talid El-Sabawi and I see the same thing when we're talking about like mental health response and things like that. And they're like, yeah, but everyone calls 911, right? And 911 dispatches police. So you are correct that we do have larger cultural shifts to make on like a broader social, you know, like what we're imagining the response to things that provide us with discomfort should be. Yeah.
I just wanted to tack on to that, you know, we talk about public health, public safety partnerships, and there's this sort of, you know, who's doing what, whose responsibility is what, who's taking the lead. You know, maybe there is a call for public health to do more of that community facing education around, like, you know, since the passage of, you know, recreational cannabis in Massachusetts, like, what is the reality of, you know, danger or incidents of, you know, harm in the state? And like, do we have a way as public health to, you know, help people understand misinformation and biases that have come from a life lived under the war on drugs? And if you've, you know, lived your entire life with the war on drugs, your understanding of drugs harms may not be reflective of the reality of the vast majority of people who use drugs without problem. And you also want to be careful too about, you know, coming up with tiered systems of, you know, what types of drugs are more acceptable and what types of drug use is, you know, more policed or less policed. So, you know, I think that there's a lot more for public health to do on the communication side and on, you know, the community facing side on education. And we see, you know, law enforcement going out there. You know, you have organizations like Law Enforcement Against Prohibition trying to do the education around the failures of the drug war. So, you know, is there more of that public health can support and public health can, you know, provide information around, you know, seeing that one of, you know, I think public health roles is being a provider of education and information to the public.
Yeah, absolutely. I want to open up if our panelists have anything to sort of talk about that we haven't, or if attendees have questions that I haven't done a good job sort of answering. But I'm, you know, before I ask any questions, I just want to open it up and see if anyone has thoughts that they haven't had a chance to sort of articulate or questions they haven't had a chance to ask.
Yeah, Emily, I just wanted to mention the, you know, we saw on the slides in the beginning, the sort of the popularity of this model, and that, you know, in your interviewing, you saw, you know, a lot of police departments sort of doing it on their own. And one of the reasons that the Department of Public Health funded this model through harm reduction programs is because if you're doing this type of community facing work and you're out there working with individuals, it's really important, you know, from our perspective, to have the support of an agency and an organization that has resources, that has community, you know, networks, where if so-and-so says, you know what, I'd like to try methadone, like, help me figure this out. You've got someone like Chris who knows the local providers and can make that timely connection to service. And you also have, you know, the infrastructure of supervision. If it's a really tough day, Chris can, you know, work with his supervisor and not just sort of be alone. And I've been really nervous about like police departments working or hiring, you know, a recovery coach on their own and not having the benefit of a full organization behind that person. So I just wanted to throw that out there that, you know, as other departments or other city, states, et cetera, consider models like this, how are you going to fund them? How are you going to set them up? And, you know, really thinking about the benefit of going through organizations to you know, bring that support of an organization behind the model so that you don't have burnout of people sort of being out there alone and, you know, not having anywhere to turn for support.
Yeah, and I mean, I think that's a really great point, you know, because as Dr. Carroll mentioned in presenting this research, these programs, at least in Massachusetts, have really sort of, you know, mushroomed, as you said, across the state. And so if this is going to be a model that other places might replicate, you know, like what advice might we have specifically for police departments who want to be involved in this? You know, like what would we say to officers? And also, you know, I think what kinds of officers might be involved and what kinds of training might we want to suggest or even require for officers involved in this? And, you know, Sergeant Costa, I'm not trying to put you on the spot, but, you know, as our sort of officer panelist, I'm wondering your thoughts about that.
No, I think, you know, it's important. The educational aspect of it is important. I think, you know, when it comes to harm reduction, I mean, you know, again, talking about the things I've learned from Chris and Mary and Denny at Healthy Streets. I mean, you know, when I first heard when they first talked about needle exchange, you know, I'm going to give needles to people, it kind of seems like, really, you're going to give needles to somebody? But when you explain it that, you know, they're trading in needles and so you're getting some needles off the street and you're giving them clean stuff so that they're not getting sick and spreading disease. And, you know, you're putting that value on a needle and things like that. You kind of understand that perspective and it actually opens your eyes to, yeah, you know, harm reduction is a good thing. I mean, you know, we see firsthand, like I talked about arresting people over and over and over. It doesn't work. I mean, it works for some people, but you know, it doesn't work. And so, you know, again, looking at harm reduction and seeing that, okay, there's all these different options and we can try to see what works best with people. You know, that's been an eye opener. So I think the big thing is education, is sharing information, you know, sharing what works and what doesn't. You know, I think, you know, we want to do the right thing, but you know, sometimes we try to do the right thing and it's the wrong thing, and we got to learn from that. And so I think that's the big thing. Is education part of it, and showing that, you know, what works and showing the results and showing that it's beneficial to do these types of programs. I think, you know, as a police officer, I believe you know, when I see something that works, I want to do it. If I see something that I don't think works, I don't. It's kind of simple way to look at it, but you know, if I show that our program is successful, then our officers buy in. It just kind of makes sense.
And I want to invite Dr. Del Pozo to ask his question. I know your hand was up in the chat, sorry.
Unmute. Hey, great. So can folks hear me now?
Sorry. Yep.
Great, thanks. Yeah, no, I'm Brandon Del Pozo. I'm a postdoc at Brown. I actually am a Jennifer Carroll, when Jennifer Carroll left her postdoc, I filled it basically. So, so I have this very prestigious lineage, but I was a police officer for 23 years, and the last 4 were in Burlington, Vermont, where I headed up the public health response to the opioid crisis. So I just wanted to maybe take a minute or two to just offer some reflections on the conversation I hear. We found that co-response after overdose was a dismal failure. And so I claimed a lot of successes in the collaborative work we did, but we found that when we, as police, responded with paramedics and social workers to people's homes after overdose, the closest we got to a response was a guy literally jumping out the back window to get away from us. And I just admitted that maybe we were doing that as police to kind of soften our image as police in the overdose crisis, but we were doing it at a vulnerable time in an unhelpful way for the the overdose victims. And the better way to do that was sort of on the front end in the enforcement and referral in lieu of arrest space, rather than the, hey, you've overdosed, now we're knocking on your door again space. It didn't work. We did hire social workers to deal with somebody, in fact, who had 23 or 27 years of clinical social work experience. But what somebody said about not leaving them in isolation was important. The only effect that we had were due to her ability to then really link with the the designated agencies that provided the care. So it wasn't like the police trying to run its own peer recovery or peer coaching type thing. It was, listen, I'm here for you. I've been looking through the administrative records. I see you're popping up a lot, not only in the overdose sphere, but you're popping up and maybe with domestic problems, with homelessness. Like, when you're ready, let's go link you to the Howard Center where you can get the help you need. And we really cultivated a close relationship with the syringe exchange. So that was critical. The other thing, I think maybe Jennifer said it, Dr. Carroll, but police definitely have an important norm setting role. And I think people were literally looking to us as guidance. Like, I hate to, falling into the stereotypes, like everybody knows what the harm reductionists are going to say. They're going to say, legalize it, regulate it, like meet people where they're at. Our scripts are quite discreetly followed. So when the police flip the script and say, no, the harm reductionists are right, or they have a good point, people go, holy cow, like that the police are saying that. And I'll give you like two really quick examples. One was the people who ran the syringe exchange were dying to get low barrier buprenorphine out of the syringe exchange for years. And their bosses were telling them, no, we're not going to do it. We're not in that. That's not the role of the syringe exchange. It's treatment, not harm reduction. And then when we looked at the data for a year or two, and then finally came to the syringe exchange and their boss and said, as the chief of police, I want you to prescribe buprenorphine out of the syringe exchange. They literally said, Christ, if the police are asking for this, like it's dogs and cats living together, we've got to do it. And they started prescribing buprenorphine out of the syringe exchange. And then we de facto decriminalized unprescribed buprenorphine in our city as an important way to signal, like, the police are saying this is not an enforcement priority. We're not going to arrest people who are seeking this treatment medication. We want people to know this is not the priority. And it had the effect of getting the public and the providers to really think about the normative value of that medicine. And then one of the things it helped lead to is the emergency department prescribing it. And the very last thing I'll say, and thank you for I just wanted to sort of download all this after hearing the conversation, was talking about education. Leo Beletsky developed something called the SHIELD model. I know Jennifer's very familiar with it, but it's aligning police occupational health and safety with harm reduction. So the value proposition isn't convincing police officers to suddenly think differently about people who use drugs, but to say, even if, no matter what you think about people who use drugs, no matter what stigma you have, it's safer and better for you as a cop to believe in MOUD and to not confiscate needles and to not confiscate naloxone. Do it for your own crime reduction interests, because it does reduce crime. Do it for your own occupational safety interests. And if it incidentally meets harm reduction goals, that's fine, but it works for you too. So I get sort of like the portrait of where we're at. Thank you very much.
Thank you so much, Brandon. That was great. And Suzanne, I know you've had your hand up. We have 2 minutes left. I've been told we have to end. Like, no, not at all. We loved hearing that, but I just want to, Suzanne, if you would, and I apologize, I don't know your title or affiliation, but we'd love to hear from you in our last few minutes as we wrap up.
Oh, hi, yes, Suzanne. I'm ex-law enforcement and person in recovery from alcohol and other drugs. LEAP UK. And yeah, it's just, it's a great conversation. And sorry, David, you seem to have got it because you are the law enforcement guy here. But again, for me, it's to go back to that overarching elephant in the room of drug reform. Overarching all of these are very outdated laws that don't work. The police know they don't work, but because of the institutions, they feel they can't speak out to their superiors because of the pressure from above, from Home Office, from public health. And that's what I find frustrating, because this is a great opportunity for globally for law enforcement to get together to sort of, put forward a manifesto of globally, we need fundamental change in policies because they drive crime, they drive the overdose rates, they drive people using drugs harmfully, so it was really more of a statement, sorry, than a question. Apologies. I was getting a bit passionate.
No, we appreciate you so much. Thank you so much. Well, I want to just thank you all so much for coming and for sharing your insights and your experiences. This has been very great and informative. And again, thank you all so much. And thank you especially to our panelists and also to our audience. Thank you so much for coming. I know we are all just so exhausted by Zoom, but we appreciate you so much. Thank you all so much and take care.